Good afternoon to all the participants. Hope you had a good Saturday so far. I'm Dr. Mohanawil. I'm the rehab physician at SJMC. So today we are going to have a very interesting topic. Okay, so as you all know, we've been fighting a war which has not ended yet, and we are looking at another wave. So past few days, past few weeks, we have been hearing of increasing cases of COVID-19. So today, to update us on what is really happening with this Omicron thing, I like to introduce our speaker, Dr. William Timothy. Dr. William Timothy is currently the internal medicine and infectious diseases physician at our Subang Jaya Medical Center. He is the president of the Infectious Disease Society of Kota Kinabalu, Sabah, and also an honorary associate for Institute of Clinical Research Center in Malaysia, the Menzies School of Health Research, Darwin, Australia, and associate investigator for the Australian Centre of Research Excellence in Malaria Elimination. He is also a member of Malaysian Medical Council Subcommittee on Infectious Diseases. He was formerly the Sabah State Infectious Consultant for 10 years when he served in the public sector. Dr. William and his team have published international journals. He received the 2017 Merdeka Award for his work as an infectious diseases physician and his research on Plasmodium knowlesi malaria. He also received the International Bill and Melinda Gates Travel Award from the American Society of Tropical Medicine and Hygiene, and the John Forbes Travel Award from the Australian Society of Infectious Diseases. Without further delay, I invite. Okay, so before the talk, I would like to invite all the questions and from the participants using our Slido QR code as been flashed on the screen. And at the end of our talk, okay, you can claim the CPD point by the similar QR code that will be flashed. Okay, shall we invite Dr. Timothy to start? Please, Dr. Timothy.
Thank you very much for the kind introduction. Indeed, the war against COVID-19 never seems to be ending, but it will end soon. It will end. So the subtopic for this very broad subject would be the implications of the Omicron variant on COVID-19 on health and vaccination. So the objectives at the end of this lecture, I'm hoping that we'll either gain an understanding on the Omicron variant, but specifically on how vaccines will help prevent or reduce the SARS-CoV-2 infection in curbing the pandemic. Mainly, one, to reduce the risk of being infected with COVID-19, reduce the risk of severe COVID-19, including death, and also reduce the risk of spread COVID-19. So, being a clinician, I'll start a bit on clinical aspect of it. These are the risk factors for severity of disease and fatality. Namely, the age of the person. The older a person is, the higher the risk of severe disease. Whether there are any present comorbidities such as cardiovascular diseases, diabetes, chronic respiratory disease, hypertension, and cancer. This is a CD scan of a patient with COVID. As you can see, very often, in many cases, when by the time the patient needs oxygen, and if we do a CD scan, almost the entire lung is involved. And this is the CT scan images of after treatment on day 19 of symptom onset. The progression of the disease, generally it's mild to moderate upper respiratory tract infections. This may differ by the different variants. The Omicron variant shows many upper respiratory tract infections, whereas the Delta variant and variants before this usually show the severe infections involve the lower respiratory tract. Dyspnea, patient becomes dyspneic and becomes more severe on day 6 to day 8, but this range can also vary. And it is an evolving disease. As time goes by, the clinical features would change a bit. Transmission-wise, initially we thought it was only droplet and aerosol. However, now it can be considered airborne. An airborne disease if you are indoors. That means to say, even if the person is about 10 feet or 20 feet away from you in an indoors environment, a person can still infect others if they have COVID. So, if you are indoors, it is considered an airborne disease. Other than that, there's contact and stool and also vertical transmission. Can airborne transmission occur? Transmission of SARS-CoV from inhalation of virus in the air further than 6 feet from an infectious source can occur. This is something very important, and many people need to understand, because initially in the first few months or even first few months, there were scientists who were warning that SARS-CoV-2 should be treated as an airborne disease because very often it behaves like an airborne disease. If it's a contact or droplet, usually the person cannot be infected if it's more than 3 feet away. Not so with an airborne disease. And this especially so in enclosed spaces with inadequate ventilation and air handling. That's why I'll just touch on this topic a bit. Ventilation is very, very important in how we reduce the risk of spread of COVID-19 in our institutions. And not enough attention has been placed into the ventilation of our buildings. So we need the concentration on exhale respiratory fluids, especially very fine droplets and aerosol particles. They can also build up in the airspace and they can also float in the air. There's also increase in exhalation of respiratory fluids if the infectious persons engage in physical exertion or raising their voices in exercise, shouting, and singing. So that is why in many religious places like churches and mosques and many places where people make speeches or sing, it's a very ideal condition for this virus to spread. And of course, prolonged exposure to these conditions, typically more than 15 minutes. So this is how a droplet spray, when the person coughs or sneezes, the droplets just go nearby within about 1 meter away. Not so with an airborne, when a person coughs, even if the other person is at the end of the room, you can still get the infection. I do remember earlier giving lectures on COVID-19, in March of 2020, and actually reassuring people that this is a droplet spread, unlike tuberculosis, where people farther away can get it. In fact, many people still think it's spread by droplet, but not so. If it's in the enclosed area, consider an airborne disease. So this is Swiss cheese respiratory virus, and as time goes by, there are more cheeses there. The Swiss cheese respiratory virus pandemic defense, it recognizes that there is no single intervention that's perfect at preventing spread. So very often people say wear mask, but you can say people who wear masks also can get COVID. Get vaccine, but people who get vaccinated can also get COVID. Don't go into crowds, but we can also say, even if you don't go into crowds, you can get COVID. So very, very often people use these reasons to say that intervention is not effective. But using this model, we realize that each intervention, imperfect as it is, together, when they are layered together, reduce the risk of a person getting COVID. So we have personal responsibilities and we have shared responsibilities. So personal responsibilities is very important for us to try and physically distance or stay at home if you are sick, wear mask, and hand hygiene and cough etiquette, avoiding touching your face. If you're in a crowded area, when you can't avoid it, limit your time there. And then we have shared responsibility, where you have the Ministry of Health and the government intervention, where there's fast and sensitive testing and tracing, ventilation in outdoors and air filtration, government messaging, financial support, quarantine and isolation, vaccines, border controls, and lockdown. So this is all a combination of interventions that reduce the disease from spreading. And we can see how easy this virus can spread. Because very often, despite all the interventions, the virus can still spread. Sooner or later, people eventually get infected. But to put it all, to simplify, if you can't remember, these are the 4 aspects that are very important interventions: mask, avoid crowds, social distancing, and vaccination. These are the 4 main interventions that I think people need to follow. Now, this is a basic understanding. Protection induced by currently available vaccines against viruses is primarily based on virus neutralizing antibodies. So what happens is, these antibodies usually block the interaction of the virus with its cellular receptor or prevent conformational changes required for the fusion of the virus with the cell membrane. So this is what you understand. The vaccine produces virus neutralizing antibodies so that the virus cannot attach itself to the human cell. So here you have the antibodies when the vaccine produces the antibodies, and when antibodies then bind to the virus and prevents the virus from attaching itself to the ACE receptors in the cells. However, there's also the cellular mediated immunity where the cytotoxic T cells recognize the infected cell. So these cells are already infected with the virus. So what happens is, the cell that is infected with the virus then becomes like a factory and starts producing more and more viruses. The cellular-mediated immunity or the T cytotoxic cells, what it does is it actually destroys the entire cell that is multiplying the virus. So T and B cell responses to COVID-19 vaccine. I know we're talking a lot about theoretical aspects of vaccine, but we need to understand it to understand how the vaccines can be effective. So these are the questions. How long will the vaccine be effective? What type of immune response it produces, and the longevity of that response. There are 3 possible immune responses generated by a successful vaccine: the production of B or T cells, or both. So antibodies produced by the B cells, they attack the virus directly, and antibodies produced by the B cell response to COVID is relatively short-lived. That is why you can see it, that the antibody levels of the after vaccination wanes as time goes by, and as it wanes, then the risk or the efficacy of the vaccine actually decreases. So it is possible that individuals who have been infected with or vaccinated against COVID-19 could develop a rapid antibody response to any subsequent exposure based on the cellular memory. Both memory T cells and B cell responses specific to SARS-CoV-2 have now been found to up to 6 months of infection. So there are 2 responses. One is the immediate response. When the person gets infected, the body produces the neutralizing antibodies that were created by the vaccine. But as you know, as time goes by, what happens is the antibody levels come down, right? Antibodies level. But this does not mean that the body cannot produce antibodies again. Within the human body, there are memory T cells and B cells, and when they're exposed to the virus, the body then produces the antibodies from the B cells, although it's not as fast as the existing virus neutralizing antibodies in the body. So similar T and B cell responses might be expected following vaccination. Selective pressure, this is something that important concept we need to understand. Selective pressure occurs when the mutant viruses that can overcome the immune system on the vaccine survive and spread. Now, this is inevitable in antibiotics and in vaccines. Selective pressure means that after a while, the viruses that can survive the vaccine or the antibiotics, the antivirals, they start to multiply. So variants of COVID-19 are appearing around the world. The concern is that it may be more transmissible, which is what we're seeing. But worse, it may be transmissible and more virulent. It may cause reinfection in people who were infected before. And 4, it may cause the vaccine to be less effective or not effective at all. The more infections, the higher risk of mutants that are more infectious and more dangerous. So that is why we cannot really have a total let loose strategy. That means to say that we just let everyone get infected. It has its pros and cons, but one of the cons is the more infections, the higher risk the virus will mutate. And we do not know how the mutation will turn. It can be more infectious, and worse, it can be more dangerous. Hence, we have to control the number of people being infected. Just because we cannot control the virus 100%, it doesn't mean that we shouldn't try and control or reduce the number of people being infected. So these are the vaccines. I won't go into detail about the efficacy because they're all outdated now. So we have the BioNTech Pfizer vaccine, Oxford, AstraZeneca, and the Sinovac. So these are the three main vaccines in Malaysia. And then Moderna, Sinopharm, Bharat Biotech vaccine, the Gamalaya, the Johnson & Johnson, and then the Novavax. And then there are a few other vaccines that have been produced. This is a study done by us showing the characterization of COVID-19 deaths by vaccination types and status in Malaysia between February and 2021. I like this paper because our country is one of the few countries where you can actually compare the AstraZeneca vaccine with the Pfizer vaccine and the Sinovac, because many countries may either have only the Sinovac or may only have the Western-made vaccines. So we can see the first point I want to point out is all these three vaccines work. All these three vaccines work in reducing the number of infections and in reducing the number of the number of severity of infections. So you can see the blue and the red lines are fully vaccinated and partially vaccinated. Very clear cut. The inactivated whole virion vaccine, the CoronaVac or Sinovac, the Pfizer and Oxford AstraZeneca, they all work in reducing the number of infections and reducing the number of severity of diseases and reduce the number of deaths. They all work. And this is another graph. And this study showed that there was advantages in the Pfizer and Oxford AstraZeneca vaccine in terms of efficacy compared to the Corona vaccine. But the point I want to share with you is not which vaccine is better, is that all three vaccines are good. All three vaccines are good. However, as time has gone by, the efficacy of all these vaccines, doesn't matter whether it's the Sinovac vaccine or Pfizer or AstraZeneca or Moderna, the efficacy of all these vaccines have waned. Here, another slide. Unvaccinated people are 17 times more likely to be hospitalized due to COVID-19. Here, there are a new phenomenon expected. This was first seen in South Africa, where you see the Delta variants now replaced by the Omicron variants that is seen in blue. This was seen at the end of December, and now the Omicron variant has spread all over the world. So these are the daily number of confirmed COVID-19 cases. As you can see, we thought the worst was over. The world thought the worst was over in the year 2020. And in the year 2021, we thought, 2 years, the worst in terms of the number of cases is over, but not so. As you can see, before this, the rise in the number of cases, at that time we thought it was rapid rise, but you look at now, it's just like a rocket. Omicron just increases like a rocket, not in one country but in all the countries. And this is not so much because of the measures placed in the country. Indeed, many of these countries have very strong preventive measures in place, but nevertheless, the virus has a big say. The number of cases just rocketed. So these are the new reported cases in the US. You can see in the end of February, the numbers have increased. The good news is, over the past 2 weeks, the number of cases, new reported cases in the US also have dropped dramatically, between 25 to 40%. You see, there's a sharp drop, a sharp increase, a rocket-like increase, and then a sharp drop. It's the same in the UK as well, a sharp increase, and then there's a sharp drop in the number of cases. Of course, during this time when there's a sharp increase, healthcare systems are likely overwhelmed, In Malaysia, we are also seeing a sharp rise now, and we do not know how high it will go. It will eventually come down, but we don't know when it will come down, but it's on the rise now. There's always, even in the previous variants, there's always a delay of about 1 to 2 months in Malaysia facing whatever the other countries have faced. So we are on the upward trend, but the good news is it will come down. So critical care admissions by vaccination status from May to December 2021. I still want to reiterate again and again, because there are many people, doctors included, who have doubts over the efficacy of the vaccine. There's no doubt at all. Those people who are unvaccinated have a much more higher risk of being ill enough to be admitted, ill enough to have severe disease, and of course dying. So those who are double vaccinated, fully vaccinated, definitely there's a decrease in number of admissions, and those who are boosted even more so. The Sinovac, and the mRNA vaccines and the AstraZeneca vaccine. People still doubt the safety of the mRNA vaccines. I mean, doctors still doubt it, but I can tell you the vaccines have saved thousands and thousands of lives. These are the variants, the Omicron variant, and then the Omicron variant, it won't be the last variant that we will face. It won't be the last, okay? We had the Delta, Alpha, Beta, and then I think soon they'll run out of alphabets, I think. So now we are facing the Omicron variant. These are mutations. All these variants have mutations in the S gene, and it can be more transmissible or possibly more virulent, any new variants that come about. Omicron of B11529 lineage, there are 30 mutations in the spike protein. So when there are so many mutations in the spike protein, what it means is that the vaccines that are produced against the original COVID-19 variants will be less effective or less efficacious against the virus. Omicron also has a replication advantage. It appears to have a greater replication rate than Delta. And it also has immune evasion. There's a higher risk of reinfection in those who have been vaccinated. So this diagram of the Omicron variant, researchers have determined that despite its myriad mutations, Omicron spike protein binds tightly to the ACE2 receptors. So usually you would think if there are a lot of mutations, it would mean that the binding of the virus to the ACE receptors would be less, but not so. Although there are so many mutations in the spike protein, they can bind just as tightly to the ACE receptors. More than 30 of those mutations are in the spike protein, the coronavirus, and it helps the virus to latch on to infect the host cells. Whereas compared to the Delta and Alpha variants, approximately only 10 mutations on their spike protein. It's been postulated that the Omicron requires higher levels of ACE2 to fuse with the host cells than do other variants. So it means that although it can bind to the host cell, it doesn't mean that it can go into the host cell. It requires more ACE2 receptors. So because the lung cells generally have much lower ACE2 receptors levels compared to the cells in the upper respiratory tract, so it tends to latch on to the cells in the upper respiratory tract. So hence, there's less binding to the lung cells compared to the upper respiratory tract. So that's why now you are seeing people with COVID-19 Omicron, they complain more of sore throat, rhinorrhea, runny nose, and cough as compared to the Delta variant, where it shows more lower respiratory tract symptoms. So more upper respiratory tract symptoms compared to the earlier variants. Omicron is very transmissible. Omicron is nearly as transmissible as measles, and that's the so-called gold standard of how transmissible a disease is. There are very few diseases that are more transmissible than measles, and it is very, very, very difficult to prevent. Almost all of us were born before the measles vaccines are out have got measles in our lifetime. Now it's almost eradicated because of the measles vaccine. And Omicron is nearly as transmissible as measles. So you can't get a disease that's more transmissible than measles. It stays longer in the upper airways, which is in a way good, because if it stays longer in the upper airways, it means that the likelihood of it going to the lower airways is less. So this expedites it from the nose and the mouth, and then allowing the virus to find new hosts. Studies provide evidence that Omicron replicates more readily in the upper airways than in the lungs. The other important point is Omicron is less virulent. Now, it's very hard, nowadays to say whether Omicron is more virulent or less virulent than Delta. Because how do you compare? Because most people now have either been infected with COVID-19 virus or already have the vaccine. So how do you say that Omicron is actually less virulent? Is it because people have already been vaccinated, that's why it's less virulent? Or is it people have already been exposed or infected with COVID without knowing it, so they have antibodies? Well, they did a test. These are animal test studies. Hamsters and mice were actually infected with Omicron. These are hamsters that haven't got vaccinated, and other variants to track disease progression. There were major differences found. The concentration of virus in the lungs of animals infected with Omicron was at least 10 times lower than that in rodents infected with other variants. So this finding is staggering. This finding is staggering. In a way, it's very, very encouraging, but it's staggering. 10 times in animal studies, the concentration of the virus in the lungs of animals of Omicron 10 times lower compared if they were infected with other variants. And not only that, other teams have also noted that compared with the previous variants, Omicron is found at reduced levels in the lung tissue, which is where most of the pathology is occurring. This is the severity of disease, coming back to real-life studies. The risk of severe disease with Omicron infection is less than with other variants. So SGTF is the Omicron variant, and non-SGTF is not. So as you can see, the odds ratio is 0.7. And compared to hospital admission, it's also less compared to the Alpha variant. Early animal studies suggest that Omicron-specific boosters offer no advantage over a third dose of current vaccine. So now they are trying to produce Omicron-specific boosters, but so far the early animal studies don't show any advantage. Well, we'll just have to wait and see. The good thing is Omicron seems to be less virulent. So no advantage yet compared to the third dose of the current vaccines. Boosters also had a positive effect on the memory B cells by inducing them to ramp up the antibodies to fight the virus. This is important because memory B cells do not act immediately, right? The antibodies from antibodies do not come immediately. It's the memory B cells that produce the antibodies after infection. So there may be a delay. I wouldn't call it a delay. So this is the second line defense. So the first line is you have your existing antibodies, and then once that is breached, then you have the memory B cells producing the antibodies to come and fight. So boosters have shown that it actually ramps up these memory B cells to produce these antibodies at faster levels and at higher rates, higher levels. So both the original vaccine and the updated jab prompted a rise in animal levels of cross-reactive memory B cells, those that target many variants and not just in one vaccine. So you want a vaccine that not only targets one variant, you want a vaccine that actually targets all the variants of COVID-19. So this is the Delta variant. As you can see, the first dose 94% efficacy, second dose 96%, AstraZeneca 71%, second dose 92%. So we were all very happy with this. But then when it came to the Omicron variant, the overall estimate came down dramatically. And in fact, we are seeing this in now in real life. That is why people are getting, the number of cases are rising. And they are also rising. They are also infecting those who have been vaccinated, those who have been fully vaccinated, including those who have been boosted. Okay, boosted. However, the the good news is that people have been boosted and vaccinated, the risk of severe disease is less. So how many boosters do we need? Omicron has changed our views on the boosters as a means of reducing the risk of infection and reduce the risk of spreading the virus. So what it means is that, despite getting vaccinated, you can still get infected and you can still spread the virus, as I explained earlier. The antibody response from the two vaccines is insufficient to prevent infections. Okay, insufficient. So if you have been fully vaccinated, you can still get infected by the Omicron variant. The response to the booster also wanes in time. So you get the booster, as time goes by, your neutralizing antibodies also come down. So in a way, we are back to square one in terms of preventing infections and preventing the spread of infections. Hence, vaccines and boosters alone is not a viable long-term strategy to prevent infections. Okay? Vaccines alone is not a viable long-term strategy to prevent infections. Priority should also be given to people or nations who are unable to even be completely vaccinated. We live in a world where it doesn't matter whether you're in Malaysia or in Africa or in China. What happens in one part of the world also affects us. So you have countries where people are getting their vaccine, they're fully vaccinated and also getting boosted. And then you have vast populations who cannot even get vaccinated in the first place. And that won't work because the mutations and variants will continue to proliferate no matter where they are. Where there are a lot of infections, mutations will occur. So the aim now is to reduce severe disease and death. Okay, reducing the number of infections and spread of the infections by the vaccine alone, as I mentioned, it doesn't, as time goes by, it becomes less and less effective. So it's important to realize that the vaccines are important to protect against severe disease, since more durable. Memory B cells and T cells remain capable of battling the Omicron even as the antibody defenses decline. So many people worry, my neutralizing antibodies are very low. They're very low. So if I get infected, then it can be serious. But not so, because we have memory B cells and T cells are low. When you get infected, albeit we want it to be faster, but the memory B cells and T cells, the memory B cells, they start producing the antibodies, and the T cells then start to get primed to attack the cells that have been infected by the virus. So real-world data from the United States, United Kingdom, and Israel show that a third booster shot of mRNA vaccine protects most people against hospitalization for up to 5 months against Delta and for 3 months or more against variant. This more durable immunity also wanes, but to a lesser extent. So the strategy now is no longer so much to prevent the disease from spreading. You have seen the skyrocketing number of cases. What is important for us is to protect individuals against severe disease. We need to boost and to shield especially vulnerable groups. Because we can't do everything at the same time. We need to prioritize and focus our attention on those people who are at highest risk of getting severe disease and dying. And also antivirus to keep people out of hospitals. Antivirus that are now out to treat the disease. So we have this treatment option. These are current antivirus. I won't go into details. There's remdesivir, there's Paxlovid, molnupiravir, sotrovimab, the monoclonal antibody, and bebtelovimab. These are all antivirus. They are available. Remdesivir is available in our country, very little, and we are trying to get the others also into the country. The vaccine that we need, the vaccine that we ultimately need, the vaccine that hasn't been produced yet, has to be longer and has to be an enduring effect. It has to be able to protect against multiple existing and emerging strains. And what we need is the pan-coronavirus vaccine that will cover all strains. So as you can see, as time goes by, with the new variants, the vaccine becomes less and less effective. This is the vaccine we need. That is longer, more durable, and covers all strains now and in the future. So here, again, I stress that in August, hospitalizations among children and adolescents increased 4 times. Indeed, now, this is the major problem now. We're seeing more and more children and young adults and adolescents getting infected. Side effects of the vaccine, well, there are numerous side effects. We cannot deny there are side effects of the vaccine. This vaccine is not an easy vaccine to take, but most of the vaccine side effects are non-life-threatening. Okay, pain at the injection site, tiredness, headache, muscle aches, nausea, vomiting, feels, fever, and chills. This, you can counsel your patients who are going to take this vaccine before they get the vaccine that they may get these side effects, and not to be afraid when they get these side effects, because they can be treated. Serious side effects, anaphylaxis, occurs very rarely, 5 in a million. Deaths, so far none have been reported directly caused by the vaccine, but now there are few deaths because of cases like myocarditis and thrombosis. But so this is an observed rate, it's higher than expected rate, and it's already been proven that there is a risk of myocarditis by giving the mRNA vaccine. Like this has already been proven, although the risk of dying or getting severe disease overrides the risk of the vaccine causing myocarditis. Myocarditis occurs more frequently among COVID-19 patients as a whole. As a whole, if a person gets COVID-19, they have a higher risk of getting myocarditis. Not so among the younger age group. The younger males, less than 40, the risk of getting myocarditis is actually a bit higher among males who are less than 40 compared to COVID-19. But don't forget, COVID-19 also has other bad effects, not only on myocarditis, it affects your brain, your kidneys, of course, your lungs. So we shouldn't just take one possible side effect that the vaccine may cause rarely to people and say that we shouldn't use it because it causes this. Because COVID can cause so many other bad effects on the patients, the COVID disease itself. Then there's vaccine-induced thrombotic thrombocytopenia and COVID-19 vaccines. Thrombosis occurs in unusual sites like cerebral veins and thrombocytopenia. These are due to antibodies directed against platelet factor 4 heparin complex, which activates the vaccines. Is extremely rare. Cerebral thrombosis has occurred in populations with the AZ vaccine. Altogether, the risk of death and serious outcomes of COVID-19, including thrombosis, far outweigh the small risk of VITT. Antibody-dependent enhancement. That's what people worried about the dengue vaccine. So far, they have none. Okay, because you see, if there is antibody-dependent enhancement, then what you will find is those people who are vaccinated now, if let's say they get Omicron infection despite being vaccinated, they should be getting more severe disease, isn't it? But we find the opposite. Those who have been vaccinated, when they get the Delta variant or even the Omicron variant, the disease is far less severe compared to those who have not been vaccinated. So this theory, although it's still been circulating in WhatsApp groups, is already totally debunked. Okay, so if the ADE exists, what it means is people who've been vaccinated will get more severe disease. But we are seeing the opposite. All right. Herd immunity, indirect protection is hope that vaccination and natural infection will cause immunity. It looks like sooner or later we will achieve herd immunity, not by vaccination but by infection itself, because the Omicron variant is so highly infectious. Okay, so this is what herd immunity means. It means that a person who is not vaccinated and is not immune is surrounded by people who are immune. And so hence, the risk of them spreading the virus to the person who is not infected is less. Okay. The proportion means the proportion of the population that must be vaccinated against COVID-19 to begin inducing herd immunity is not known. Estimates between 70 to 90%. For example, measles requires about 95% of the population to be vaccinated. Polio, the threshold is about 80%. So will we achieve herd immunity? I think eventually we will achieve herd immunity because of the vaccine and also because of the virus infection. So this is just a nice diagram to avoid yourself, and how you can advise people. The best is to be if unvaccinated and unvaccinated, the risk of each infecting the other is very high. The risk of them getting severe infection because of the high viral load that is going into them is high. So for those, the best is to mask and vaccinate. Okay, so both parties are masked and both parties are vaccinated, and this will reduce the risk of spreading the virus from one person to another. I hope, I mean, I'm speaking to an audience of doctors. I hope that with all the information that we have, that we would not have any doubts on the efficacy of the vaccine in preventing or reducing the risk of severe disease and death. I know there's been a lot of bad press in the sense that the vaccines have not prevented infection, people from getting infected and from the infection spreading. And we have to admit it has not performed as well as we wanted it to. But what it has done, and that's very obvious, is that it has reduced the risk of severe disease and death. So these are the choices that you face. You either be infected with COVID-19 without a vaccine and hope for the best, or you be vaccinated with COVID-19. You may still get COVID-19 with a lower risk of severe COVID and death. So these are three choices. Or if you don't want to be vaccinated and you don't want to get infected by COVID-19, you isolate yourself totally, and that is impossible. So my friends, we are all in this together. We have all gone through a very, very difficult 2 years. These times will end, and we'll have to get this through together. With that, I'd like to thank you very much for your kind attention.
Thank you, Dr. Timothy, for the very elaborative talk. So now we have some understanding regarding this Omicron virus and how important that we all get vaccinated, and we should be encouraging our patients, our population to get vaccinated also. Okay, so I invite now for the participant to clear their doubts. Okay, so I open the floor for any questions. So you can chat with us the questions. Okay, while you type your questions, I would like to get some questions to Dr. Timothy. Dr. Timothy, since we are all, I mean, most of our participants are from the GP group, so I would like to know, what is your advice for them? How can we protect, because they are the first contact with the patients who comes, and usually this upper respiratory tract is that complaints are the very common ones that they see. So how do they protect themselves other than masking, vaccinating, and all that? Do you have any particular advice for them?
Okay. Actually, if you're vaccinated and you're masked and the patient is masked, and in addition to that, the clinic is properly ventilated, there's really actually, in practical terms, not much more that one can do to reduce the risk of getting infected in the workplace. However, I have to add that many doctors and many healthcare workers do not get COVID-19 in their workplace. Okay, it's counterintuitive, right? You think that you get the infection when you go to work because many people come in, but when you go to work, you're wearing a mask, you're fully protected. Many people healthcare workers get infected in the community and in their homes. So, for instance, for me, when I go to work and I see COVID-19 patients, I will wear a full PPE, I'll wear the mask, and I'll wear the face shield. But when you go home and you're with your children who have gone to school, although they may be wearing masks and there it's so easy for them to get infected, is the risk of you getting infected at home and when you go out is actually in ironically higher than at your workplace. So the question is how do we go about earning a living? How do we go about working if there's a risk? I think we have to accept that it is an occupational hazard. So coming back, how do we reduce the risk other than wearing a mask, other than being vaccinated, other than the patient being masked and screening them out? I think the thing that we need to look more into would be, which we haven't done before, is ventilation. All right, proper ventilation of our clinics and in our hospitals, and that's something important. Right. The other thing is to reduce the crowd in your clinic as well. The number of people at any given time in the clinic, and because then that would mean the concentration of the virus, if someone's infected, is higher, and the risk of spreading to people is higher. So there's always a crowd in the clinic.
Yeah, I guess so. So it's important that we tackle all that preventive measures. Okay. So any questions? Okay. There is a question by Dr. Renuka Nambiar. Okay. Any studies on development of cancer following vaccine? Is there any increase in cancer cases following vaccine? Yes, Dr. Timothy.
Actually, not that I know of, I presume the vaccines have just come up in the last 18 months or so when many were vaccinated. So if you were to develop a cancer so fast after the vaccine, that has not been seen. And people may argue that, you may get cancer 5 years down the line or 10 years down the line. But we have to realize that cancers, the cause of cancers and also autoimmune disease for that matter, very much is multifactorial, isn't it? Very much is multifactorial. It's not so easy to pinpoint a single factor that causes cancer. So the answer is no, or rather I don't know. There's no evidence. So I suppose if there's no evidence that it can cause cancer, I don't think that we should tell patients something that has not occurred, or rather warn them that they might get cancer, although it's not proven yet. So no.
I hope that answers your doubt. Okay. Dr. Timothy, there is an ongoing drive of getting children below, 5 to 12 to get vaccinated. Okay, and you mentioned in your talk that there is a rise in the cases in the children's district. So, what do you think that a lot of parents are very hesitant to get their children vaccinated? So, thinking about all that side effects has been going viral. So, what is your advice to the parents, and how do the GPs can reassure them?
I think the two unknowns. One is the fact that when a person gets a vaccine, we do know there are possible side effects that can occur, and hence when a GP is advising for the vaccine, we can give the because I think we are not supposed to be advocates. I suppose we just have to tell them the truth, that just like any drug that you're giving, that there is a risk whenever you get the vaccine or any drug. The risk of myocarditis, I think in boys is maybe about 20 to 30 per million, roughly like that. That there's a risk of fever, there's risk of allergic reactions. So while we know the risk of the vaccines, but what about the risk of COVID-19? See, what can happen if a child gets COVID-19? They may get multi-system inflammatory disease, and they may get severe COVID. So parents need to balance this risk and benefit. So as GPs, what I would advise is, just like any other drug, give them the risk and benefit. But overall, my personal opinion is I think children should be vaccinated. They should get the vaccine, the first and the second vaccine. At this moment, most doctors are not prepared to give such an assurance on the need for a booster yet. Okay, the need for whether children need a booster vaccine or not. But I think the general consensus is that children should get the vaccine. There hasn't been any consensus on whether children need to get the booster or not.
Thank you. That's clear.
I hope I wish I could give a more clearer evidence-based answer to that. But we do know vaccines reduce the risk of severe disease even in children. Although COVID-19 in children in general doesn't cause severe disease, but the risk of severe disease, if it does occur, occurs much more less frequently in children who are vaccinated.
Thank you, Dr. Timothy. There's a question. Okay, so with this Omicron variant, when do we start antiviral treatment?
Okay, for any viral disease, we need to start viral treatment as soon as possible. Unfortunately, we haven't got this in our country yet. We have to realize that there are also people who just can't mount the immune response after vaccination. Okay, people who are very immune suppressed, patients who have cancer, patients who have immunodeficiency syndrome, where you can vaccinate them a few times and they still can't mount the immune response. So antivirals are very, very important for this group of people. Now, for everyone else, antivirals can still be used, and if it's used, it needs to be used early rather than later, because the viremia starts to go up, especially after day 3, day 4, where the virus starts to replicate. That's where the antivirals are given. So antivirals, even late in the disease, is usually not effective. But if it's given, it has to be given as soon as possible. We hope that antivirals will come into the country as soon as possible.
How is the process going on now? I from the news that we get that our neighbor is already acquiring it.
I think we should do it faster. I mean, yeah, I can't answer that question. Okay, sorry. Okay. It should be faster.
Any more questions? Yes, got that one. Okay. Regarding this antiviral, Dr. Timothy, okay, about whatever the existing antivirals that we have now, like that anti-HIV and so on, does that have any benefit?
I mean,
just do as a prevention and all that.
I mean, we've tried using Calitra and for treating the COVID. It hasn't worked. The new antivirals contain ritonavir, which is one of the antivirals that is used for HIV patients, but it's always used. It's used in combination with another antiviral. So I think your question is whether the existing anti-HIV drugs can be used for COVID-19. They've used Calitra, but it should not to work. So antivirals again are very, very important. I think it is important as we move towards therapeutic, treating patients with COVID. And especially so, and this is very important, not everyone who is vaccinated can develop an immune response that's adequate to prevent infection or even prevent severe disease. So for these people, the antivirals are very, very important. Very important. certain percentage of people, vaccination doesn't do any, they show no benefit.
Okay. One last question before we end this webinar. Okay. So no question from the floor. So I would like to raise one more. Okay. So there is, I mean, some time ago, if you remember, okay, so ivermectin was in the news quite often. So there a lot of GPs has been in dilemma whether to use ivermectin or not in as a prophylaxis or in terms of treating. So it's kind of died off now, okay, but still there are some people who are some people are still in trying to use this medication. So what is your opinion on that, Dr. Timothy?
I think there's a paper that just produced in the JAMA Malaysian study itself. Malaysian study shows there's no benefit in using ivermectin. Okay, I think there's a question here. It said that Omicron evades immunity even in those highly vaccinated with booster population. Then why are we giving booster when it's not effective? Okay, I think in a sense, okay, the first part, is a booster effective in preventing infection as much as we want it to? Yes, it's not as effective in preventing infection. Even reduces the risk, but it doesn't prevent it. And even the risk reduction is not as high as we want it to. However, as I showed, the studies show that it actually helps prime or boost the memory T cells and the memory B cells. Okay, don't forget that. We always think the efficacy of vaccines in terms of the level of neutralizing antibodies. And we all know that the neutralizing antibodies come down, but the booster shot primes the T cells and the B cells. And the studies have shown, I think I've showed just now earlier, that although it doesn't reduce the risk of infection that much, it does reduce the risk of severe infection. And that is the reason why it should boosted. The booster is very, very important, especially in those who are at high risk. Okay, so when we say that giving booster is not effective, effectiveness can be interpreted at different levels. Effectiveness can be, you may rightly say that it's not as effective as we want it to in reducing the spread of the infection. That arguably may be true, but it is important in reducing the risk of severe disease and death.
Thank you, Dr. Timothy. That's a very enlightening talk. So, Omicron, okay, is terrorizing us now, but fortunately, okay, so that hospitalization rate and severity rate is still low. Okay, our hospitals are still able to cope with the load. Okay, so we fight with this war together. Okay, so we have to take all the preventive measures. Okay, so we always mask up. So we always wash our hands. Okay, we avoid crowded places. Okay, and all the other measures. And all of us hopefully get boosted, and all of us wish all of us safe living. And to end this talk, okay, so we will you can claim the CPD point, okay, by QR code on the screen now. Okay, have a good day. Okay, and enjoy your weekend. So any further questions you can direct to Dr. Timothy. at our SJMC mails. Okay, have a good day. Bye-bye.
Okay, thanks.